his own views. So we welcome you very much and look forward to your talk.
Thank you, Richard. It's a pleasure to be here. When Richard asked me to talk about the heart with ultrasound and MRI imaging, I thought, what I'm going to talk about, especially with this audience, which is different from the way we give a talk, because now as a patients and in public and they want to know about it, so a bit of it going to be jargon, so I have to talk in the different sort of a language, but still maintain the high quality of the talk. And it was a challenge because it is very technical. The things that we do and the lots of this information we give is, although some of his opinion, but there's lots of opinions based on the knowledge and the investigation trials that is already being done. So it was a challenge. I tried to use your logos. So I said this is for this meeting. How do we look at the heart? There are two main modalities to look at the heart. This is old-fashioned of just tapping on the heart, seeing the heart is big, look at the X-ray, look at the silhouette of the heart, is it big or not? Those days are gone. We now have some best modalities to look at the heart, and the one that we look all the ways with it is the echocardiogram. And we are lucky in this trust to have at least 3 of these machines, the state-of-the-art echo machines, to assess the heart function and valvular function. But we are also privileged to have the new state-of-the-art MRI machine. This has just started about 18 months ago, 24 months ago. That we purchased this machine and we can do a more detailed examination of the heart. And I'll give you some brief ideas as when they are useful. So to put this talk together, I thought, how can I talk to the patients who are interested in arrhythmia, especially in AF. So it is more oriented towards the arrhythmia, the talk overall. Imaging has played an important role, as Richard says, in defining cardiac sizes, defining the heart function, cardiac function, and defining valvular function. But especially MRI has added significant values to the way that we look at the heart. And I'll give you lots of examples when we go through. So the first few slides, quite a lot of them, is a bit boring, all about talk, but I'll give you lots of examples when we go through in different patients. MRI has provided comprehensive evaluation of the heart in terms of the function, in terms of size. The similar things that we get from the echo, but with added value of tissue characterization. That we can look at the heart muscle and see whether it's, for example, is a scar, and that scar adds value in terms of the prognosis, diagnosis, and the management, especially in patients who have history of sudden cardiac death in the family and arrhythmia. And this is the overall pictures what MRI can do. It is not as good as you can see on my screen, but overall we can look at all aspects of the heart. The things that we can do with echocardiogram, for example, in this view, you can look at the heart in terms of the heart valves. It is less likely we can get these sort of beautiful images in terms of the coronary arteries. We are not as good as, say, CT scan or coronary angiography to look at the coronaries. But if someone asks me whether you can look at the origin of the coronary arteries and the direction, by some maneuvers we can do that. We can look at the perfusion, look at if someone has got ischemia or not, but more importantly we can look at the outside the heart, with the vessels, which echo would not give that answer. The advantage of MRI to CT scan, for example, is does not carry radiation, we don't give iodine, and although we give contrast on some occasion, this contrast is relatively extremely safe. It's got its own side effects, but it's relatively safe, much safer than iodine that we get. It is well established in patients with congenital heart disease, although we still do the echocardiogram, but MRI is very useful. Just getting dark in the pictures. And also, extracardiac structures such as this one, which is a pericardial cyst, which may not be seen on the echocardiogram. And I said I've got lots of examples of these to show you. In terms of the arrhythmia, again, MRI has got a significant role, especially in finding fibrosis, and where the fibrosis scar is, and because that helps the interventionists, the EP doctors, electrophysiologists, to map the area that they are interested in, so it was a less time in the lab, and to do what they want to do. And I'll show you some examples of the scar. If the scar is within the myocardium, it will tell you whether you have to go there externally or internally in order to ablate or to look for the ablation. Again, in patients with sudden cardiac death history, the presence and the assessment of the scar, it helps us to risk stratify them, for example, if they need an ICD. This is on top of all the electrophysiology study that we do to establish a cause for sudden cardiac death, where we look at the structure. This is purely, I'm talking about the structure here, but there are other things that can cause a sudden cardiac death which cannot be seen on the cardiac MRI, just to be aware. For example, we can look at for the ischemic cardiomyopathy with the MRI. We can look at this in non-ischemic or dilated cardiomyopathy. We can look at the hypertrophic cardiomyopathy and the risk stratify, AR-VCN, and so on and so forth. Let's move on. This is, again, things that I told you, that presence of the scar, which with delayed enhancement, that's the use of gadolinium, has significantly improved our knowledge in terms of the risk stratification and management of the patient in sudden cardiac death families. Again, I probably have got better images, we'll probably move on. This is the pattern that we normally see. This is a pattern recognition when we do the MRI. If, for example, this is the one that somebody with a heart attack may get, this is the transmural infarct. There are what we call it here subendocardial infarct, for example. If there is an evidence that the patient has got a VT, for example, it helps the interventionist to direct the ablation to this, which is from the inside the heart, and if it's the subepicardial, they can go outside and do the ablation. So it really helps the interventionist in terms of management and in terms of the treatment. And obviously, first of all, make a diagnosis. This is a paper we published about 2 years ago with collaboration with Brompton. They looked at the patients who had dilated cardiomyopathy and to do risk stratify. We already have some risk stratification. This is the level of the LV function, how bad or good the function is, and few others. We thought that by adding the MRI and by adding the delayed enhancement and scar detection, could we add values to prognostication of the patients? Why is that? Because many of the patients, we offer them ICD, may not even require it at any point, or ICD itself has far from expensive, it carries a risk, complication, and so on. Is there anyone we can, better stratify these patients? We looked at these quite a number of patients. It doesn't show up at all. These are supposed to be graphs showing the people who had the fibrosis compared to those who do not have a fibrosis. It carries significant risk on top of what we already knew. So this was published in JAMA and is one of the highly cited papers in the past few years. And this is the sort of things we're getting. This is again patients who had dilated cardiomyopathy. We showed if they have a scar, I don't know if you could see it from there, if they have a scar, which is this white bit within the boundary of the heart, the dark is the heart, and this is a scar, and this is on the autopsy, which is on exactly the same thing. So this is, you don't have to autopsy someone alive. You can see this. These are the, then this patient have higher risk than somebody who does not have this scar. People who have a dilated cardiomyopathy, about a third of them will have this sort of pattern of a scar. About 10 to 20% have a different pattern. They show us, again, I've got a good example to show you, which shows they have had an MI, myocardial infarction, without knowing it. So this is something that you will not see it in the echo standalone, because echo, this is the scan of the heart, is show you the heart is not pumping well, but it does not show you what the cause is. So it helps us to find the cause and direct the management. Now, let's talk about the AF. What is the role of the echo, or ultrasound of the heart? This is to look at the chamber of the heart, the size, which is very important, especially left atrium, the heart function, left ventricle or right ventricle function, valvular function, people who have a mitral stenosis or the MR, the risk of having the atrial fibrillation, and also look at the pericardium. Patients may have a tamponade, a pericardial effusion, or constriction, which may lead to AF. So this information is useful in diagnosis, causes, which can lead to the AF, and the management. For my patient, this is again personal opinion, anyone, almost everyone who has got AF has to have an echocardiogram. And we have seen a time after time the patients, we have no symptoms whatsoever. The first time they come in with AF, they have heart failure. But there are certain groups, the subgroup patient may need a TOE for various reasons. And there was this study, which doesn't show whatsoever, but I'll tell you what it showed. Is a study that they looked at the patient with atrial fibrillation, and to see whether, if they go through the TOE, transcatheter visual echo, which is a probe going to the gullet and have a look at the heart from the inside, whether that adds any value compared to the echocardiogram. So if the patient had a TOE, and these are the high-risk patient already, with that CHATS VAS score, which is the patient with the heart failure, either had a previous MRI or stroke, age more than 75, diabetes, heart failure. So we already know that these patients should be on warfarin and anticoagulation one way or another. So if we do the TOE, would there be any other information helping us? Which patient would benefit from the anticoagulation or maybe aggressive anticoagulation compared to the others? There were 4 criteria they found. One is if there is a clot in the left atrial appendage, is a bit of part of the left atrium, which usually the clot sits there, or if there is a spontaneous echo contrast with a stagnation of the blood within the left atrium, which is another sign, or if there is a complex aortic plaque. Or that the flow within the left atrial appendage is slow. It means that if you have any of those, that increases the risk of a stroke by 3 to 4-fold. So it not only adds values, it helps to take patients that you are the one who have to take the medication regularly. What we don't know, whether we should increase, for example, INR levels to slightly higher or not. We don't know yet, but that's what the study showed. We know for a long time the size of the left atrium is important, and this is the study done in, I'll show you next one, the study done in Framingham Heart Study. This was started in the 60s, probably when I was born. And the patient been followed up for a long period of time. And this is the study, very simple study, because the echo machines at that time was not very great. They didn't have much information. But what simple measurement of the left atrium, when they measured the 44 millimeter atrium, this is not even very big, if they followed them up, these patients had high risk of developing atrial fibrillation. Just a simple measurement. And obviously we know that if the patient has got a high atrial size, there's an increased risk of recurrence after ablation or DC cardioversion. So we can stratify which patient should go for the further treatment. Okay, and in terms of what is the role of the MRI in AF patients, I don't think everyone with the AF should have MRI, but there are certain groups of patients who will benefit from MRI. And I'll show you another study which shows an advantage and incremental values of doing the more advanced imaging. Apart from looking at the scar and knowing what the cause of the heart failure, for example, might be, it shows us the shape of the left atrium, the sphericity, the way that it's become that shape. It just helps us to de-risk-classify the patient. The size of course, is another matter that you can look. But there is another thing we looked at with the MRI, to look at the fibrosis within the left atrium. There are several ways of looking at it. One is prior to ablation. If the patient has got fibrosis within the left atrium, and we can grade them 10, 20, 30, 40%. If there is the lesser fibrosis they have, the more chances of success and more chances of maintaining in sinus to them after ablation. So you can say, if you want to direct the patients towards a treatment center, if your fibrosis is small, before the ablation, you are the most likely to benefit from it. But if the fibrosis is massive, and I'll show you some pictures of it, then it's less likely to benefit, because within a year, about 70% of it will go back to atrial fibrillation. But MRI has got limitation in this subject, because left atrium wall is very thin, and the spatial resolution of the MRI is limited to about 1 to 1.5 millimeter. And when it's become thin, and a thin layer of the scar, that's not always easy to identify. Let's move on. This was a study which was done, I was talking about, and this is a methodology, and that's, it probably is not going to show, but what it showed basically, as I explained to you, it will show that if you have a high degree of the scar, it's more likely that you will go back to the AF after the ablation within a year. Now, if I move on to the examples, so hopefully that will be a more exciting bit. And it just shows me, I'm afraid it doesn't show, it took me ages to get these pictures. This is the patient, is a 56-year-old chap. I think it was the last year before I went to a holiday, came to Rapid Access chest pain clinic with some atypical symptoms. Really, if you ask him, there was no chest pain as such. But he had an abnormal ECG. It was a Q wave, which is a diagnostic of a previous MRI. But when I asked him, he said, not really, I do go to the gym. In fact, he was a football coach, and so I do run around all the time. There's nothing. But the GP was worried about the ECG, and then since then, was anxious to send us to us having a rapid access chest pain clinic. But what I saw him to say, look, let's have an echocardiogram. I don't have the images to show you, it's probably in this one. But he ended up having an MRI and angiogram later. So this is sort of the pictures we saw briefly on the echocardiogram. Don't think it shows, because of the brightness here, as good as I want to. But basically shows his left ventricle is dilated, it's baggy, but also shows that part of the muscle here is not contracting as good as the rest. This gives us an idea, a clue that this part probably is dead or is not functioning as it should. The next step to do, apart from these beautiful pictures that we took, to look at the gadolinium scar. The scar that you can see here, this is the white within the black. The black is the muscle and this is the white. And the white almost is bigger than the black. So this is a gentleman, not knowingly, at some point suffered an MRI, a massive MRI, which has blocked one artery. And if you look at this, goes all the way right to the tip of the heart. He had an angiogram and it shows a block in one of the arteries, which is called LAD, left ascending left arteries. But one question was whether we should do something about it. Because everyone knows there's a knee-jerk reaction. When you see a blocked artery, you think you have to open it. But knowing these pictures, we said, no, hang on a second, it's not going to benefit. It's a dead muscle. And when you have the area which is more than 50 to 75% dead from the muscle, there is no way you can benefit from the stent. You can put a stent, you can see the flow going through, it's not going to do whatever. Not a bit. So it helps us to reduce further intervention. In fact, he came back several times because he was anxious, and we had to just reassure him. There are other treatments he can maybe offer. His LV function was not too bad, but we can't do risk stratifying whether he would require ICD or not. So he's under the follow-up, or he's fully treated. And we did the perfusion scan, obviously not going to be seen in these pictures, but didn't show any defect. It showed that fixed defect in the same area that we thought about. So although the area was ischemic, you could see it at rest and after the perfusion. So another clue that you should not touch him. This is another young chap admitted to our ward here in CCU. He had chest pain, abnormal ECG, and high troponin. So when he was seen by the medics, we started him on what we call it ACS protocol, or heart attack protocol, with aspirin, statin, the rest of it. Luckily, we had the slot that we can put him under the magnet, this MRI, and you can see that his images are good compared to the other one. So his heart is pumping very well. But when we did the further imaging, this is, I wasn't sure, this is the stare imaging or edema imaging. We look at the amount of water within the heart muscle. We saw that it was a significant amount of, as I say, it doesn't show contrast, but the MRI, you really need a good contrast between the thing to see. What we see is, usually if you come to the echocardiogram MRI, we live in the dark rooms. Really dark rooms, so you are a bit boring to be in a bright room. You can see the extra. It's a sort of a whitish compared to grayish here. Just all I can say. I can show you later in my computer. The pictures are much better there. And then when we did the scan of the gadolinium, the scar, you can see the scar tissue, what we call a subepicardial. So it is not starting from the inside the muscle. It starts from the outside. So this is clear-cut diagnosis of pericarditis. But these patients, not everyone with pericarditis gets these pictures, but this again is telling me this patient needs to be followed up. These are the patients when we have seen later on in the life develop heart failure because of the scar and the rest of it. at the moment is entirely normal, his function is good. But I'll show you pictures of the people who have had myocarditis in the past, who developed the MRI, developed the heart failure in the future. So that was him. And this is a patient, again, admitted to our ward with the ventricular tachycardia. Like I said, this is the arrhythmia session, so we'll talk about loss of AF and arrhythmia. Again, LV function is not too bad. It doesn't, again, project as good, but there was a certain area which is not contracting as good as what we expected. It is what we call a lateral wall. And when we apply the gadolinium or scar detection, you can clearly see there's a scar there. Can you see the white? Mm-hmm. Yeah. So, so this is the white. That's a scar. That's here. And we get a different cuts because you may get an artifact with different cut. This is what we call a transmural, which is affecting the whole of the muscle. It's gone. But we found something else. He also has the scar that I show you in the mid wall. Remember the other? So he's got dual pathology. So someone come in, so the question was, where is the VT coming from? That would help the interventionists, the electrophysiologists, if they want to direct the treatment in terms of the ablation, whether they have to go here or direct it to this muscle here. So it's very useful to have this information. This is an elderly gentleman. He was, again, in the stroke unit, admitted with stroke, but he had a very high troponin, so we were asked to see him. He had no chest pain, no significant ECG changes. We had lots of patients like this we see with the high troponin for various other reasons. But we have to risk stratify who should go under the further investigation, who should say this is purely for other reasons. But he was very interesting because they could not find a cause for a stroke, and he could not explain why he had a high troponin, which is a marker of the heart muscle damage. So he came for the MRI. Again, function slightly low. It's not as good as the other ones. But when we applied the gadolinium, it was very interesting. We show a different pattern. You can see here, there's like a dot in the mid-septum and another dot in the lateral wall. This is the one we normally see at an embolic event, which means that there is a clot somewhere, we don't know where, maybe had an atrial fibrillation, leading to the stroke, or and the heart rate at the same time. So it's very interesting. But now we have to direct this treatment towards an embolic event and to see what the cause was. This one? Okay, this is the one we receive very frequent. This is the patient with left ventricular hypertrophy, query cause. Sometimes they never had a high blood pressure or not documented high blood pressure, no family history or whatever. Echo, although sometimes we pick up very, very good information from the echocardiogram, is not as sensitive as MRI. So this patient, if you look at this here, let's show you. This bit is much thicker than the rest of the myocardium. If you look at the septum here, this one is like a donut, and this bit is much thicker than the rest. So what we call it asymmetrical septal hypertrophy. And when we apply gadolinium, that's a scar, and you can see in the hypertrophic area of the muscle that is thick, we get the scar. This is sort of a pathognomical of the hypertrophic cardiomyopathy. But at the same time, we can look at, in fact, Richard suggested to me, before I get the headaches with this, why don't we do it for all the blood pressure? Can I have an imaging modality that when I send the blood, especially young patients, we can look at everything. There are several reasons, for example, can patients have a high blood pressure. One of them is looking at the coarctation, which is a narrowing of the aorta. You can look at the renal artery stenosis. You can look at the adrenal glands. We can look at the heart muscle, where the patient, for example, has developed a side effect of high blood pressure with hypertrophy. We can look at the muscle function altogether. So why not? We can do this test all together. So for this one, we run a few tests while we're waiting for the gag. That's aortic valve. It shows a small leak from the middle, but the valve is tri-leaflet, opening well. So it hasn't got a bicuspid valve, which is another risk factor. We clearly know he hasn't got a coarctation. But the reason for his left ventricular hypertrophy or thickening of the heart muscle was an inherited cardiomyopathy. It's called hypertrophic cardiomyopathy. Right, this one is another patient with abnormal ECG in AF. The problem with the MRI, sometimes the patients with AF, we do not get the good quality as the echo does. The reason is because we rely on the ECG, what we call the ECG triggering. There are other sequences we can apply, but not always work. So sometimes the image quality is not good. In fact, this is not too bad at all. So this is the patients that we did in the real-time imaging without the ECG triggering. So we asked the patient just stop breathing, then we took images. Again, this is slightly different from the other one. And if you look at it, which doesn't show good, is got hypertrophy in the apex. If you look at this is the base of the heart where the mitral valve is, and then the tricuspid valve is opening. And usually this is the thicker part of the heart compared to the apex, which becomes gradually thinner. And you can see that, appreciate the difference between the sizes. Obviously, you've got the different angles to look at, and this is the patient who has got apical hypertrophic cardiomyopathy. So different from the other patient. Whereas we applied the gadolinium, although we did not see any gadolinium apart from touch here, there was no significant gadolinium enhancement or the scar in this patient. There are other modalities that we can use. We are good at look at what we call a replacement fibrosis scar, but we are not good at this methodology to look at the interstitial fibrosis. But there are more images, more sequences coming that we can apply with the MRI to look at the more details of the interstitial fibrosis. How are you doing the time? Yeah? I've got a few cases to show, so you don't need just, I'm sorry for the brightness here. It shows really in the dark rooms, and images usually use the dark rooms, which is better. Okay, this is another one, and the young patient of ours who had an abnormal ECG. This is the one referred one of my electrophysiologist colleagues. Got a patient who's got abnormal ECG. We don't know what causes. The echocardiogram is normal. Can you help us? Again, the function is good. It's just mild thickening in the septum, but it's not as bad as the other one I showed. When we apply the gadolinium, it was a touch of a scar in the septum, which is here, and I'm afraid you don't see it, and just you have to trust me. And there is another one when we cut it on this far. So we made a diagnosis. This patient's early stage of the hypertrophic cardiomyopathy, but it has got, in terms of management, it has implication for his family screening and the rest. And we can talk about it, but just briefly, if you have any question, you can ask me later. Why is it important? How is it going to change the management? Right, another AF patient is an 87-year-old who had recurrent collapses. Now, we will question whether this is due to his AF, it's going too fast or too slow. It can be either of them. So we stopped all the antiarrhythmic medication just to assess, but at the same time we decided to do the MRI. And when we did the MRI, we found that he has got another patient with hypertrophic cardiomyopathy. Sorry, I have to go back. Let's see. Another patient with hypertrophic cardiomyopathy. If you look at the septum again, is quite thick compared to the rest of the myocardium in here. So, although it didn't have a scar, another modality we can try and see how this area, which is thick, if I show you in this views, we can create boxes within the heart muscle. If you look at these boxes compared to rest, the rest contracts well, this area it doesn't. So this is another view which we look at the echocardiogram, so not only visually we can see it, we can just do other tests to look at this. This area, which is thickened, is not functioning. So every extra muscle doesn't mean that you have to do stronger. It's not like you have bodybuilders. You built up a lot, but it doesn't function. So when we apply the gadolinium, which is looking at the scar, we didn't see any scar. So we can risk this transfer. Look, we didn't find any scar. He's got hypertrophy, so he has a low risk. Why don't we start with the pacemaker, rate control, and see how it goes. So you can see how different there's different prices for the ICD. It's got different implications compared to just a normal pacemaker. So change the management with just the imaging. Right, this is a very interesting one. This is a 43-year-old who has been seen by our colleagues back in, I think it's Harley Street or somewhere in London. I was diagnosed with hypertrophic cardiomyopathy with significant gradient across his left ventricular outflow tract. And for several years he's been followed up. He had, although some of this information we gathered later, this is not how presented to us, he had atrial flutter ablation, atrial fibrillation ablation, some of them successful, some of them were not, so he's been going through a lot. He came to hospital about a year ago with acute asthma attack. He's also asthmatic. While he was treated, he had a VT arrest. He had to be shocked, taken to ITU. I saw him following there in ITU. So we did the echo, it was abnormal, then we gathered all the other information. Unfortunately, image quality on the echo was poor. Some people don't have a good image quality with the echo. Some of you may have gone through this. Some of the quality is good, some not, for various reasons. But his was not good at all. We knew that heart was not pumping very well, but we could not establish anything. What we knew, that the gradient had disappeared. We knew that he had a gradient across the LVOT, but it was not there anymore. Because he was unwell, I was asked to do a transesophageal echo, put a probe down to look at, make sure he hasn't got a clot, to give him another shock to see whether we can get him out of the atrial fibrillation, atrial flutter, which we did so. But we also arranged for him to have an MRI. And this is his, different angles of the MRI we do. What we found at the same time, he had a chest infection, which you don't see, but he was on treatment. And then when we did the imaging, and you can maybe appreciate that his function is not good at all. It's very severely impaired. He has some leaky valves because of the heart muscle is stretched, and the valve which holds things together and now is stretched, so it's leaking. But his function was poor. When we apply the SCAR study, this is another images, just a move. When we apply, this is the gadolinium enhancement. Unfortunately, it's become brighter and brighter by minute. I can't see. If you look at again, is just try to remember this is the heart muscle, the black and the white is the scar. The amount of the scar is more than the muscle. So his heart is completely scarred. He's very young considering his amount of the scar. If you look at it, if you remember all the other pictures I showed you, there is more white than the black. Is it further images? But it was rather unusual. The unusualness was, when we looked at the scar, was in what we call a subendocardia, was within the muscle and outside the muscle, almost everywhere. It didn't fit in with any of all the pattern I told you. But I knew he had hypertrophic cardiomyopathy. It was done by my other colleague several years ago, and the report now has come back, it's got HOCM. What happened to it? What I think, we did all the other fancy stuff, all the rare stuff to see whether he's got any of those, he had none. What has happened now, what we call it the burnout hypertrophic cardiomyopathy. This is the end stage heart failure. So you had more scar than the muscle that you cannot distinguish what he has. But he underwent to have an ICD and he's still alive.
Oh, good.
And he's doing well. But from time to time he comes to hospital with heart failure and various reasons. But at least he's still alive. But we can risk stratify, he needed an ICD. For several years he had all the tests done, but now we have a documentation. He had a VT, he required a shock, quite compromised, so he needed an ICD. This is another patient, I think was referred from Ashton to us. It was a 78-year-old who was an HS, short of breath, although when I talked to him, I said, no, just my age, 78, you would expect to be breathless. But had loss of ectopic, the missing beats, that's what we call it. And was waiting, but had a cancer. So the surgeons were very keen to go and then do an operation, but they wanted opinion. When we did a scan of the heart and everything was okay, so we said that's fine. But can I exclude any angina? Is this breathlessness due to angina or just breathless because of age and other reasons? And breathless is one of the difficult ones to assess. So we did the perfusion scan. I don't know if it's showing good. If you look at what happens is, this is the whitest of what is coming is the contrast. What we normally do with perfusion scan, we give a drug called adenosine. And when we run it for 2 or 3 minutes, we allow the coronaries to vasodilate, to become bigger, And then the area which is under-perfused becomes less perfused, what we call a Steele phenomenon, but that's the technical word. But what happened was the area which is under-perfused gets darker. There's a darker rim from the subendocardia, and she definitely had one. She went to, so we referred to for an angiogram. She went to angiogram. At the same time, they do further tests. I didn't know. When she came back, I knew, and they confirmed that she definitely had angina. So we had 2 tests confirming one after another. Now, this is the young chap last year. There was a marathon in Epsom. He was admitted to us. He was a doctor. He lives in Southampton, but he was running here. He collapsed outside the Epsom. So he brought to us. It was very fortunate. He came to us. He had no chest pain, but his ECG is abnormal. His blood test, there was some muscle damage. So what the question was, what is the cause? So there are several things we can look at. He has a hypertrophic cardiomyopathy. Has he had a heart attack? Has he had a dissection? Has he had what? So we did the MRI on him. Again, he was lucky. One of these that we could put him under the magnet. Most of the time we cannot, because these things is not elective. It is mainly elective rather than emergency, although occasionally we can do. We saw that there is no dissection. This is aorta, which is beautiful. This is the pulmonary artery. We saw the function of the heart. They're all fine. See, we did the tagging. This is the one that I showed. This was normal. So all bit of the muscle is also functioning well. And when we did edema, we look at the amount of fluid in the heart muscle, which sometimes goes with the pericarditis, heart rate, almost everything has damaged the heart muscle. If you do it quickly, we can see. Didn't have one, and there was no evidence of a scar. And we already know some people who run the marathon are at risk of having this. It probably was just dehydrated. But we can tell them and reassure them that there is nothing wrong with the heart. Nothing has happened. There was no damage to the heart muscle despite the blood test showing it. But also occasionally we can find a few things. In this one, I found a lung lesion, so I referred that to my respiratory colleagues to look into it. The other one had a scar in the top of the lungs, but when we looked at the old images, he already had that. That's not to be. So I think I finished here. Sorry that the images were not great. It took me a long time to prepare them, especially to make sure that they're running, but they were too bright here. But if anyone wants to look at them, you can come and look at the computer. But I hope that I managed to convince you that having the imaging has changed the management of our patients. We invested quite a lot to have the MRI here, and then gradually we're getting more and more patients referred for the same reasons. It helps them, it helps my colleagues and myself to see how we can manage the patients, how to treat them, and how to influence the outcome.
Well, thank you very much. That was very good.